Kia ora koutou. My name is Kate Barbie, Support Coordinator for Fertility New Zealand. It's my pleasure to welcome you tonight to Fertility New Zealand's webinar, Add-ons and Research Update. This year's Fertility Week campaign is entitled I Am 1 in 4. Any of us can face challenges building whānau. 26% of Kiwis facing infertility during their lifetime, affecting men and women equally. It can impact any New Zealander, regardless of factors such as ethnicity, education, urban, rural, and religion. The campaign aims to support and educate people who are currently trying to conceive, educate, reduce stigma, and raise awareness amongst people who are affected in the future. For those of you not familiar with Fertility New Zealand, we're a registered charity. We walk alongside all people facing fertility challenges. We have a dedicated helpline, and we provide support, information, and guidance to anyone at any stage of their journey. Please check out our website for more information. Presenting tonight's webinar, Add-ons and Research Update by Professor Cindy Farquhar, Medical Director of Fertility Plus and the University of Auckland. Thank you for being with us tonight, Cindy.
Thank you.
If you have any questions or comments tonight, please type them into the chat box. Cindy will respond to questions at the end of the presentation. If there is anything that you'd like to put into the chat box earlier, please do, and they will show up at the end of the presentation. So thank you for joining us tonight. We hope you enjoy the webinar. Over to you, Cindy.
Okay, so thank you very much. Thank you to Fertility New Zealand for inviting me to be on the program and give this presentation. So I'm Cindy Farquhar. I'm from the University of Auckland and Fertility Plus in Auckland, and shout out to all the Aucklanders who are still in level 4. And if you think I'm looking a little bit scruffy, it's because I haven't been able to have a haircut now for 8 weeks. So envious of those of you who are still who are in the rest of the country. So I'm a fertility specialist and researcher at the University of Auckland and the Medical Director at Fertility Plus. And these are my declarations of interest. I've had research funding from the Health Research Council, Auckland District Health Board, and the Auckland Medical Research Foundation. I have no financial relationship with the IVF clinics or any commercial companies. This seminar will cover IVF add-ons, including the scientific evidence supporting their use and aspects that people having IVF might like to consider. And I'd just like to emphasize that it doesn't replace the clinical advice from your doctor or fertility specialist. So what are IVF add-ons? They're also known as adjuvants or optional extras. There is no established definition, but it's usually something optional or additional to a standard IVF cycle. The claim is that they would increase the chance of IVF success, having a baby, and there would be usually an extra cost to the patient. It may include clinical and laboratory medicines, techniques, and procedures at the IVF clinic, and it can include alternative or complementary therapies and nutritional supplements. So IVF add-ons are not necessary or required parts of an IVF cycle. So IMSI, for example, is not an add-on if it's for male factor infertility. Genetic testing for inherited conditions is not an add-on. Having an endometrial biopsy or a laparoscopy taken as part of the investigation for fertility couples is not an add-on. And time-lapse embryo incubation used to improve the workflow for embryologists wouldn't be considered an IVF add-on. But on the other hand, in the other column, if you're having IMSI just because, or without having non-male infertility, that would be considered an add-on. Testing your embryos for aneuploidy, the wrong number of chromosomes, is considered an add-on. Endometrial scratching is an add-on if it's just as an add-on in addition to the IVF cycle, as opposed to an investigation. And time-lapse imaging, when it's claiming to improve or increase your IVF success and charging you something, is considered an add-on. So I'm just going to briefly talk about something that may sound a little surprising to you, something called evidence-based medicine, and that's something that perhaps most of you would hope that medicine is evidence-based, but if we look back in the past, evidence-based medicine was not well understood or practiced. And so this is something that we consider to be important in making clinical decisions. And we do, clinical decisions really involve the clinical judgment of the doctor, the patient's values and preferences, and the relevant scientific evidence. And that evidence will come from randomized control trials and systematic reviews. And I'll explain some of this shortly. So effectiveness, i.e. does this add-on increase live birth rates, and safety, does this add-on carry any risk for me, to me or my pregnancy, comes from randomized control trials and systematic reviews. And then the patient's preferences and values, as I say, I'll talk about that a little bit later, is around the rights, the values and preferences, the shared decision-making, and informed consent. Just having a moment here, sorry. We have a little bit of a duplication there, apologies. So randomized control trials are when people are allocated to groups at random. For example, you could flip a coin and be in one particular group, or you could pull lots out of an envelope. And this is when people will receive a treatment according to this random allocation. It's part of a research protocol, and it's called considered the gold standard for evaluating healthcare interventions. It's not always possible or ethical, but it is usually used for IVF add-ons, and certainly for most of the modern treatments that you receive now, there would be randomized control trial evidence behind them. So here is the design of a randomized control trial. You can see there are all the patients who are going to get treatment A, and then the patients who are going to get treatment B. And there's the researcher in the middle of that diagram recording the outcomes for patients in those two groups. So systematic reviews are summaries of all of the available studies, and generally they're restricted to randomized control trials. So an individual randomized control trial is one thing, but if they're combined in a meta-analysis to give an overall result, then that's a much more powerful type of research. And each of these systematic reviews will also include a critical appraisal of the quality of the individual studies. And generally this requires some training and skills and enthusiasm for doing this. And so what we have here, if I take you to this figure, which I can't quite get my pointer to work, but at the top of the figure, identify the issue and determine the question, write a plan, and then you have a group of studies. You sift through those studies, extracting the data, assessing the quality, and I'll skip to the bottom, and at the end of it, after doing some analysis and seeking conclusions, then you'll have a systematic review and able to disseminate this. So I'm going to talk a bit about Cochrane reviews in particular. So Cochrane produces something called the Cochrane Library. So it's just like an electronic journal. Anyone can find the Cochrane Library in New Zealand if you search and have access to it. It's publicly available. It's led by an international group of trained researchers, and they produce the highest quality systematic reviews with good, robust methodology, reliable results, and critical appraisal, which means looking at the studies carefully. It's independent with no funding from commercial companies. And we have free access to this in New Zealand, as I've said. So here is the front page of the Cochrane Library. You've got a little search box at the top on the right-hand side there, and you can put in 2 words there if you wanted, acupuncture and IVF, and you click the search button, and you will get a Cochrane review on that topic. And here it is here. And in particular, you'll get an abstract at the beginning, and it's to determine the effectiveness and safety on acupuncture as an adjunct to ART cycles for male and female subfertility. And there's the plain language summary for that on the right there. And when you open that up, you can read through it, and I've just highlighted it and brought out the key results. There's no evidence of benefit for the use of acupuncture in participants undergoing assisted conception treatment around the time of embryo transfer or at egg collection in terms of improving live birth rate, ongoing or clinical pregnancy rate, and no evidence that it has any effect on miscarriage rate or significant side effects. So the Cochrane collaboration or the Cochrane Library has a special collection of IVF add-ons that you can look for, and you will find there's an editorial here as well, and they've been grouped into laboratory add-ons, clinical add-ons, and add-ons for the endometrium, and so you can look into those. So this is sometimes known as the traffic light system of the Human Fertilisation and Embryology Authority, HFEA, which is a UK-based organisation that regulates IVF and monitors IVF cycles in the United Kingdom. And it's fairly obvious. You have red, no evidence to show that it's effective and safe, and you have amber, where there's a conflicting body of evidence and further research is required, and green, where there's more than one good randomized controlled trial which shows that the procedure is effective and safe. And as you can see on the green line, currently there are no add-ons under this rating in the HFEA. However, you can also see a list of other add-ons there. Some of them are red, and some of them are amber. So here's the example of what you would find for endometrial scratching. And we've got the traffic light system on the left-hand side, and then they describe it here, what is endometrial scratching and what's the evidence for this. And so you can go and have a look at this yourself, and you'll see that at the moment it's got an amber rating. And they update this every so often when new studies come in. And I just wanted to talk to you about a study that some of you may have been in. If anyone was in the PIP study, thank you very much for being in this study. It was led from New Zealand, and PIPS was shorthand for Propel, and which is a type of device for making an endometrial scratch. We did a large study across 5 countries and 13 centres. And I'm just going to put one more slide up about this study, which was published in 2019. And just to show you the live birth rates. And as you can imagine, half the women in the study had an endometrial scratch and the other half didn't. And this is from one IVF cycle, so a single embryo transfer, and majority of them. And here are the results. The live birth in the scratch group was 26.1, and the live birth in the control group was 26.1. So it's a fairly conclusive study and a way of doing studies to show whether or not a treatment might make a difference. Now, it's very hard for doctors and patients, etc., to see those results if they're just looking at their own group of patients. And so this is the power of a randomized control trial. I hope you would be convinced that there is no evidence in this study that endometrial scratching around the time of IVF or embryo transfer is beneficial. So I'm just going to run through a few common add-ons that we have. Time-lapse imaging, also known as the Embryoscope, and there are some clinics in New Zealand with it. This allows for the continuous uninterrupted incubation of embryos, and this means that the embryos won't be disturbed for assessment, and instead of removing them from their dishes and examining them under the microscope, you can look at them directly using the time-lapse systems. And they use algorithms to help pick the best embryos. Now, in Australia, it's now offered in around 33% of IVF clinics in Australia, and several of the New Zealand clinics as well. And in this particular study from Australia, around 22% of the IVF cycles patients had time-lapse imaging, and that cost them extra around 27% of the time. So there was an extra charge, I should make that clear. So we do have a Cochrane review on this. It was updated in 2019. It included 9 studies and didn't show a difference in live birth rates, pregnancy rates, or miscarriage rates. It's also been assessed by the HFEA as amber, which means that there was conflicting evidence. Now, it's not to say that it's not a good idea to have one, because they're efficient and a very useful part of the fertility laboratory. It's just whether or not you would want to pay for that additional cost and add that on to the cost of your IVF cycle if you're having to pay for a cycle. IMSI, which is an ultra high magnification of sperm selection. Sperm are normally viewed under the microscope and selected on their morphology, but IMSI will provide 6,000 times their magnification and could hopefully improve the selection of the best looking sperm. And this is offered in clinics in Australia and used by about 6% and costs additional money for couples about half of the time. And again, there's a Cochrane review on this. It was updated 2 years ago, 13 studies, no evidence of a difference in live birth rates, pregnancy rates, or miscarriage rates. And HFEA have given that a red light. And then we have embryo glue, which is hyaluronic acid in the embryo transfer media. It's a natural compound found in the body. It acts as a binding and protective agent. It's often added to embryo transfer media with the aim of helping to implant the embryo. And again, it's offered in IVF clinics in Australia and in New Zealand, and in some patients, in Australia, 22% of patients were being charged an additional amount for it. And there's Cochrane review with 26 studies, and it concludes that it probably increases the live birth rates and pregnancy rates. The HFEA have given it an amber at this point in time. And then this is perhaps one of the newer add-ons, intrauterine infusion of HCG before an embryo transfer. And here's a little brochure about what actually happens. And there is a Cochrane review on this with 17 studies, nearly 5,000 women, and it showed it improved the live birth rate for women undergoing day 3 embryo transfers, and that's now being offered by some clinics also. And now I just want to talk briefly about the Colorado protocol. It's for recurrent implantation failure, 2 or more failed embryo transfers. Protocol involves aspirin from the day 1 until the end of the first trimester, and is thought to improve the blood flow to the uterus, and that in turn helps with the implantation at the endometrium. The second part of the protocol is prednisone or methylprednisolone for 7 days around the time of egg collection, and that's to suppress the maternal immune response and increase implantation. And then the third part of the protocol is antibiotics for 7 days around the time of egg collection to reduce the microbial colonization within the upper genital tract, so to reduce the chance of a low-grade infection that may occur. And there's a Cochrane review for each of these. The first one for aspirin, it hasn't shown any benefit in live birth. The second one, it doesn't show any benefit with prednisone. And the third one with antibiotics, also not showing any benefit with antibiotics. But very few studies in some of these. There's one non-randomized study of the Colorado protocol, and they looked at patients having treatment in an IVF and FET, frozen embryo transfer cycle, and they had matched controls. So that's another way of doing a study. If you don't randomize, you can look for similar patients. And they found no difference in live birth rate, clinical pregnancy rate, or implantation between the 2 treatment groups. And I've just put those results there for live birth and clinical pregnancy rate. If it's 1, that means that the 2 arms of the studies are balanced, and that there's no evidence of an effect. And so that just leads me on to tell you about a survey that we've been doing, and I'm very happy that Fertility NZ have the survey on their website, and it's still open. And and so far over 400 women in New Zealand have completed the survey, and if you're one of those, then thank you very much. You go in through the news and research part of the website, and you'll find this, and you'll be able to do it. It's a reasonably short survey, and we will be publishing the results in the coming months. So, do we have conflicting evidence or no evidence? So sometimes we think that there's conflicting evidence, and sometimes there just aren't the studies there. So just remember that without good evidence, we don't really know what the effect of an add-on is. It may actually be harmful. It could reduce your chances of conceiving. It could be unsafe or have some unintended consequence. For example, in the endometrial scratching study, the PIP study, 7% of the women in that study had bleeding in the few days after the scratch, which perhaps we could have predicted it, but it's certainly not what you want when you're planning an IVF cycle next. And it could cost you so much that you regret it and that you can't afford more IVF, although most of the add-ons are not as expensive, of course, as an IVF cycle. And you may have not had looked at the scientific evidence, but you may have had anecdotal evidence, and this is quite strong. There may be information from family and friends or through online forums. I totally understand how this works, because you're just wanting to look for some way to improve the outcome of your fertility treatment. So you hear that something worked for them. People, of course, are much more likely to tell you about their positive experiences or their negative experiences, and perhaps not so much if they're neutral. People will often overlook a coincidence and attribute success or failure to special circumstances. For example, you could be having an IVF cycle tomorrow, and you decided to have a banana tonight. Would you think that the banana had anything to do if you did get pregnant? But eating the banana, that is. But if you'd taken some aspirin or some other medication, then you might think, oh, maybe that was what worked, and then that gets passed on to people. So these anecdotal accounts generally are biased and not helpful. Of course, they are helpful because in other ways it might be useful to hear about the anecdotes, because you do get to hear other people's experience. You can hear about the availability of an add-on and the cost, and it does raise possible other treatment options. But it's not useful to know whether an add-on is effective by just having a conversation. You need to go a little bit deeper than that. So back to evidence-based medicine, and this bubble here that I was talking about before, the rights, values and preferences, and shared decision-making and informed consent. Where does this come in? So I'm encouraging you to think about, this is something called Choosing Wisely, and I'm encouraging you to think about this. There are 5 questions that you could consider when you go to have healthcare, whether it's IVF or any other form of treatment, or making a decision around treatment. So first of all, you'd say, do I really need this test, treatment or procedure? Then you might ask, what are the risks? You might ask, are there simpler, safer options? What will happen if I do nothing? And what are the costs? And this is a website that you can go and look at, and I think it's very helpful. So what are patients saying about IVF add-ons? Now, this comes from a website in the United Kingdom, or a report in the United Kingdom. It's at the bottom there, where they did extensive interviews with patients and about add-ons. So you can find this. So this is I think reflective of the range of impressions and views that people have. So the first one is, there's no proof of success, but it's a peace of mind thing, and I think that's very very true. The next one, many years, finally a baby. Best choices I ever made was not to give up and to keep try all the extras. They told me what a scratch was and how it could be beneficial. So at that point, it's like, it's only an extra £250. We might as well try it. If it doesn't work, then you're going to think, well, if only I had spent that extra £250 and it could have worked. On the other column, I feel we were unfairly made to purchase add-ons that did not give us any extra chance, just left us out of pocket. For me, and the next one, personally, it's made zero difference so far. My very first cycle, my husband and I used no vitamins, no add-ons, and we have a son from that cycle. Every subsequent cycle we've used add-ons, and so far we've had no success, sadly. And this last comment, when a doctor mentions an experimental drug like testosterone, you immediately think it might give you an edge and be the thing that does the trick. But I now think my rational mind was compromised during that time, and that testosterone was no more likely to help than eating an orange or standing on my head. So I don't know how you feel about these comments, but we often hear back from our patients, and I think they're quite honest and open, and quite challenging as well. And so this leads into the ethics of the ART add-on. So the term ART, I'm sorry, is assisted reproductive technologies. And this is a publication about it in one of the medical journals. Do a la carte menus serve infertility patients? So the idea is that you come into a restaurant and you're given a menu and you choose what you want. And then the same with fertility treatments. You're presented with a range of options, which can be quite daunting. And this is the ethics and regulation of IVF add-ons. So mediocre success. My first point here from this paper is that the mediocre success rates can drive add-ons and also remuneration. So if we're always looking, we always want our fertility cycles to be more successful, to be better, to be as good as they can. And so that has driven this great interest and promotion of add-ons in some cases. That there's little regulation of IVF clinics in some parts of the world, and I don't really apply that to Australia and New Zealand. If there is informed consent, how should we do this when there's uncertainty, when we don't know what the outcomes are going to, whether or not there will be an improvement, and how to be impartial when payments are paid. So it becomes a bit of a commercial decision, which is also quite challenging. And so we need to provide some factual information, and we need to also be able to communicate that sometimes, and it's not popular to say it, but sometimes we don't know the answer to some of these questions. Now, the Fertility of Australia is a society for the fertility clinics across Australia and New Zealand. And in 2019, they had this technical bulletin, the use of adjuvants in ART. And it was an attempt, I think, to improve the way clinics were offering add-ons and improve the information that patients would get. So the recommendation is that in order to minimize any risk, RTAC, which is the accreditation committee, and the Fertility Society recommends that all ART units should provide patient access to a list of adjuvant therapies, provide appropriate and accurate information regarding the effectiveness, including the strength of the evidence, the risks if known and not known, advise patients of the uncertainty of the risks and the costs of any therapies, and that the unit should ensure written informed consent is obtained for all adjuvants. And so I'll just show you, I'll show you shortly what an informed consent form looks like, but it's informed consent is enshrined in our patients' Code of Rights. It's an important part of all healthcare decision-making, and it relies upon accurate and relevant information about the proposed intervention, alternative options, understanding the benefits and risks, and an opportunity to ask questions. And this is an example of informed consent. So this consent is for the use of, and you put the name in here, it could be, say, Intrauterine HCG alongside my IVF FET cycle. We've had a discussion with the staff member about the chosen add-on. I've been given the information sheet regarding it, had opportunities to ask questions. We understand the effectiveness, including the strength of the evidence for using the add-on, the risks, if known and if not known. I've been advised of the uncertainty. We've been informed of the cost, and we've been advised of all the above information by the clinic and are choosing to undertake the named add-on. So this is my last slide. So there are many different IVF add-ons that are available, but few are supported by scientific evidence of safety and effectiveness. We really want trusted information, and I'd encourage you to ask about the research behind any new add-ons. Are there clinical trials? Are there reviews? What does the HFEA website say? And then what's important to you, is it the reliability of the evidence? Is it the cost? Is it the risk? And how will you feel afterwards? So thank you very much. This is the end of my slide, and I just want to thank Sarah Lenson from the University of Auckland and Jeanette McKenzie from Fertility Plus for helping me with the presentations. Thank you. I think we have time for questions now, and here we go. Thank you.
Hi, Cindy. Thank you for that. That was really interesting. A great presentation. A few years ago, I was part of the PIP study, which resulted in a live birth. So that was really interesting to see those results as well.
Which arm were you in, Katie?
I was in with Fertility Plus.
No, which arm of the study? Did you have the scratch, or did you have the control?
I had the scratch, yeah.
You had the scratch, okay.
Yeah. Yeah.
Good.
Yeah. So that those results were quite interesting to see. Any questions for tonight? Please chuck them our way. So we'll get going. I'll just pop off again. There's some questions coming up very shortly, Cindy. So thank you very much.
Okay. Okay, so I'm being asked about something. I'll be totally honest and say I can't tell you the answer to that. Severe atopic eczema, any studies about inflammatory conditions, and I would be guessing. All I could say is that some of the more common treatments are safe to use during fertility treatment and in pregnancy. So someone's asking, do I ask the question this way? Yes, so just pop your question into the chat box there, and yeah. Now, there's one slide that I seem to have dropped out somewhere. So while I'm just waiting, oh, here we go. I've got another question then. You mentioned IMSI is not an add-on if it is male factor. Does this mean it is not available or is given to anyone doing IVF with male factor for free? Ooh, I'm unpicking that a little bit. So the so IMSI, fantastic development. So just to remind you, IMSI is when the sperm is directly injected into the egg, and it's usually done in the situation where the sperm are too low to be in enough of a concentration or to be able to fertilize the egg directly. And when you look at any groups of people in infertility clinics, you find about 20 to 30% of people may have a male factor, and so you'd expect IMSI to be maybe 20 or 30% of IVF cycles. But in fact, it's got, over the years, people have started using it more generally. And so in some parts of the world, it's as high as 80%, and I think in New Zealand and Australia, it's between 50 and 60%. And we don't entirely understand why. And sometimes it's because there was no fertilization at all. And so they may, in the subsequent cycle, decide to use it. And sometimes we're hedging our bets, you know, that half the embryos will be from ICSI and half will not be. But it does come with a cost. It's of course more expensive. It takes a lot more time for the laboratory, and I think that the jury is out a little bit. But generally, we're not recommending ICSI for people who don't have male factor infertility. If you do have male factor infertility and you're a public patient, it will be part of your IVF cycle. And there's no additional cost for public patients having it. Okay, so somebody has asked me, when did the FIX study begin? It began in August 2019. And if you ask me when it's going to finish, I hope it's going to finish in 2023, in the first part of 2023. And the recruitment is going very well, but every time we hit a lockdown, which we've just now had our second level 4 lockdown during the study, we do have a drop off, and so we might just have to extend that a little bit further into 2023. If anyone's interested in the FIX study, I haven't covered it at all. It's not an add-on. And there is the website. If you put FIX in the University of Auckland, you will find out about that study. But you have to be recruited through the clinics. Okay, right. I did my first cycle in Australia and it resulted in my 2-year-old used embryo glue during transfer. Is embryo glue funded in publicly funded FET cycles, or do I have to pay extra? I meant to look this up. I know that in one or two of the clinics, it's part of a routine part of the cycle. And I think that might be the case across most of the clinics in New Zealand. So I think it's now becoming standard business as usual, kind of, not an extra charge. But I know in Australia that in many of the clinics, it's still an extra charge. Okay, so there's another question about the inflammatory conditions. And you're curious about whether that's why you've struggled to conceive. And I think it's kind of impossible for me to answer that question, except to say that some inflammatory conditions can be very widespread and affect many of the cells in the body. And so it wouldn't be unreasonable to think that if you've got a widespread inflammatory condition, it may be a problem. And but I think I probably should stop there because I shouldn't really go into too much advice. Okay. Do you have any recommendations for add-ons to consider during total fertilization in an ICSI cycle? Yeah, so that's a really challenging situation, and so that's where none of the embryos have fertilized in spite of ICSI, and I think that that you'd have to explore look into a number of reasons for that happening, and then you really have to make the decision that you've got to do it again. And that, I think that is the thing about, I haven't really covered this off yet, but a single IVF cycle will really many women, the majority of, or more than half of women who have an IVF cycle will have to have a second one in order to have a baby. And so you can have total fertilization failure or low egg collection numbers, and then you need to go. It's like getting back on the horse and doing it again. And I know that's hard. And we clinics probably need to be more realistic about the expectations that you have with just one cycle. And I think, that's, if you're doing public funding, that is, the reason the government funds 2 cycles is because the clinics, ask them to do so, because we know that 1 cycle is not enough for most women. So if you do have this total fertilization failure, I'm afraid the best advice is to do it again, checking off all of the factors that might have led to that. And yeah, I'm sorry, it's a hard call, I know. Is IVF the best option for a couple with male factor infertility? So with male factor infertility, checking off all of the tests that the man must, that are encouraged to do, especially if it's very low, then it is generally the best option is IVF with IMSI. I think that's what that question means, not IVF. I would say with male factor in general, all things being equal, it would be IVF with IMSI. Mild male factor, there's which is kind of, you're just below the threshold for what normal is. There's a few other options, including IUI is maybe an option. What are your thoughts on embryogen? I haven't had a chance to look at this one, I'm sorry, in a detailed way. I know, so I have to say no to that. I can't answer, sorry, disappointing. I know that we are looking at doing some work on this one, so yeah. Yes, you do have to have a frozen embryo transfer if you choose pre-screening of embryos. There's really no way around that, because it takes time well, the biopsies are done, and then the processing of the screening takes time to get the results, and yeah. So, yes. Might be at risk of finishing early, or have I missed another one down there? Okay.
Hi, do we have any last questions for Cindy before we end the webinar? We've just our last few. Just watching Facebook as well, so there's just a few more coming through Facebook Live.
Oh,
so
okay. All right.
as well. Yeah.
It's a bit hard to fill in the empty space, so when I was just saying before about, doing another cycle, I guess that's one of the things I think that you probably want to consider is, do you want to, save your money and have another whole cycle? perhaps, instead of spending money on add-ons in an earlier cycle. So you just need to think about that. Are there any add-ons that help people with endometriosis? I don't believe there are any that are specific, and that's a really good question. And I do know that, you know, there's a bit of a trend to do some hormonal suppression. Well, not a trend, there's some evidence for doing hormonal suppression for women with severe endometriosis before they have their IVF cycle, so that the endometriosis is medically suppressed as much as possible before. I don't think it's particularly good evidence, and that's an area that would be good for further research, but there are some studies on that. So 3 months of medical treatment before you start your IVF cycle.
It looks like that's the end of our questions for tonight, Cindy. So, yeah, thank you very much for your time tonight.
Okay, well, thanks everybody.
Thank you.
Good night.
Thank you very much for your time, and yeah, we hope to see everyone again tomorrow night. And our last webinar for tomorrow night is the cost of infertility. So make sure you tune in tomorrow night and join us with Dr. Greg Phillipson. So thank you once again for your time tonight and the great webinar, very informative. So thank you very much. We've got lots of thank yous coming through now as well. So thanks for your time, Cindy. Good night.